Hello, everyone. Thank you for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to support and educate families of premature babies. This Premature Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here, every Friday, we talk with experts, researchers, and parents to share with us their experience and knowledge. Also on our website, canadianpremise.org, parents will find all kinds of resources and support. It's been 1 year now since we launched the COVID Care Program, which is a program offering free therapy for families who are currently in an ICU or a year post-discharge. To apply for the COVID Care Program, you can visit the resource section on our website, which is canadianpremise.org. And right now, we are going to talk about optimizing critical care for premature babies. We will discuss the changing epidemiology of complications among premature babies in the NICU and evolving demands of skill sets among clinicians, how these needs are fostering the growth of newer technologies, quality improvement initiatives, and research endeavors for the provision of better critical care in NICUs. We will talk about the emergence of neonatal hemodynamics and targeted neonatal echocardiography as a neonatal subspecialty and the impact in acute complications among premature babies. And I have here joining me from Toronto, Dr. Amish Jain, who is a staff neonatologist and clinician scientist at the Sinai Health System Tannenbaum Lunenfeld Research Institute, and also an associate professor in the pediatrics at the University of Toronto. He's also the site director of the Targeted Neonatal Echocardiography program in the NICU at Mount Sinai Hospital, which he co-founded in 2011. During this time, Dr. Jain also completed a PhD in cardiovascular physiology in the Department of Physiology at the University of Toronto. Dr. Jain, thank you so much for joining us here today. Can you hear?
Thank you so much, Fabiana.
Thank you. It's such a pleasure having you here. And for our audience, we are going to have a presentation and a Q&A at the end. So please feel free to make your comments and ask questions, and we'll address them at the end. So I will share my screen. You just give me one moment. I hope everybody can see now. And Dr. Jain, the stage is yours.
Right. Thank you so much, Fabiana, and thank you for everyone who's given their time to come and listen to what I have to say. I do have to give up a preface, first of all, that I'm using hospital's Wi-Fi network, and sometimes it times out after 45 minutes. And if that happens, then I will log back in. You just have to bear with me for 20 seconds. So, right. So I think without wasting too much time, as Fabiana said, I'm a staff physician in Mount Sinai. And what I really wanted to talk about is something which is a bit of a passion for me, is about provision of critical care for premature babies. And I think we can go to my next slide, Fabiana. So before I say anything, I do want to make some disclosure so that people can put this in context. First of all, these are my personal opinions, and they do not represent either my institute or my department's opinion. They are completely in my personal capacity. And these views that I'm sharing are not a reflection of my local practice or regional practices that I have seen either in Toronto or in my hospital, but they're just my overall take on the progresses that have been made in neonatology as a subspecialty, and what I feel after working in this specialty in many countries over the last 12 years. And my intention here is not to be critical either of the past or of the current practitioners or practice, but it really is just my passion for advocating for provision of quality critical care and moving the field forward. And I just want to make sure that my passion doesn't come across as I'm actually whining. I'm not whining. I'm just advocating. Right. So with that disclosure, let's move forward. Right. So this really is the main thing that I want to sort of share. This is just my thought process. As I look back on neonatology from where I read, as I look at the literature from where we have come around, it's a very new field compared to all other adult fields. We only started providing intensive care to premature babies in like 60s properly. And if we look at sorry, Fabiana is controlling my slide animation, so it's a little bit challenging. So if we look at the issues that we used to have at that time, a lot of our work for a majority of part was about respiratory distress syndrome. I'm sure most of you were already aware of that. That the surfactant deficiency is a major problem in premature babies, which can result in a lot of complication in the first few days of life. Something like pneumothoraces, they need so if you look at the studies from 60s to 90s, a lot of them focus primarily on these issues. In the starting period, there was very limited research, and there were no real standards. So the skill set that the clinicians needed at that time um, were mainly, they were very physiologists, which is quite exciting for somebody like me when I read the research that was done in 60s and 70s, because they had nothing else to go by. They were all sort of physiologists at the bedside. They'll look at subtle clues. The ventilation management was very physiology driven. There were a lot of innovations that had been tried. Now, there's obviously a downside of this also, because the knowledge wasn't there. But a lot of innovations and out of box thinking used to happen at that time and get published. It has got both pros and cons to it, but nevertheless, physiology, especially respiratory physiology, was a major part of it. But if you look at the research at that time, a majority of research deals with the first 3 days of life. What that led to? It led to a lot of discoveries. It's completely transformed the way we look after babies in just a span of 20 years. And this list is not exhaustive. It just highlights some of them. The surfactant become available, different types, and it's everywhere. Antenatal steroids were discovered in RDS, and now we use it as a standard of care. Caffeine came around for apnea prematurity. Postnatal steroids to improve lung disease. Antibiotic prophylaxis to reduce early onset infections, to the point that the early onset infection are really a small proportion of our total infection we see in an ICU now. High frequency oscillatory ventilation was discovered. Conventional mechanical ventilation, which was volume guarantee. A lot of non-invasive ventilation support came around, like CPAP at that time. And the nutritional approach was the focus. But if you look at, there was one common theme in all these studies, and that's been the case till now. They tried to solve problems that are common to all, so all babies approach, rather than individualized, because at that time these were the common problems which were affected by majority. And what that led to, and this is my training period starting from 2005 onwards, when I started training. We didn't really have that much of trouble in the first 3 days of life in preterm babies, as my seniors used to tell me, or as I read. The term honeymoon period was often used, and why that was used, it basically what they're trying to say is that the first few days of life in a preterm babies are probably their best days. They are so stable, and people used to call it honeymoon period, because after that things may go downhill, or complications might start. We discovered new BPD. Unlike the old lung injury, the new BPD was chronic lung disease, which was not as bad as before. A lot of non-invasive ventilation and developmental care became a focus, because we start focusing on family integrated care, developmental care, gentle approaches, unlike the previous years when we were just struggling to keep these babies alive in the first 3 days. So it's a very big change, from having to struggle really hard for the first few days, to the point that the first few days are the least work that you have to do for these babies. So what that's a good thing, obviously, but there was some downsides to this change. The skill sets that were being developed at this time point, and if you look at our literature, you will find a lot of quality improvement strategies, hands-off approach, gentle care, and protocol driven care actually came about in this period, and for good reasons. That was the demand of the time. But what that led to, in my opinion, is the previous skills that our clinicians have gained with so much hard work, which were primarily dealing with RDS in the first 3 days, they were no longer as relevant. The RDS management started becoming, at least in the tertiary centers, start becoming on an almost like an autopilot mode. It's not something we lose sleep over giving surfactant anymore. The new skills that were required now, they were just not enough teachers there because people haven't done that. And it also resulted in an overall decline at the bedside of applied physiology, because we had evidence, we have generalized prophylactic approaches and all-comer approaches now. We didn't really need that much physiology at the bedside, and unless if you don't use it, you tend to lose it a little bit. The diagnostic skills went down a little bit. The out-of-box solutions, ability to think problem through, went down a little bit because it wasn't needed. And the procedural skills, and that's all the training programs we speak about are actually dealing with that problem, that the procedural skills, just the opportunities are not enough, and that's why the skills are a little bit going down. These were just the trade-off for providing all these quality care in general to all the preterm babies, and it has resulted in a lot of improvement in survival overall. So what happens now, though? If you look in 2020, the majority of times that we are struggling now in the NICUs, or we are working really hard, is not the first 3 days of life RDS pneumothoraces. It's really is critical illness. It's things like shock, things like pulmonary hypertension, acute respiratory distress syndrome, multi-organ dysfunction, either from sepsis, neck, antenatal complications, rupture of membranes, and stuff like that. These critical illnesses are the ones that we have to respond to, because everything else is more or less take care of itself. But if you go forward, if we click to the next animation. Oh, there was an animation there which missed out. Okay, so what we was trying to say there is that these critical illnesses are now the main diseases that we have to deal with as a physician point of view. But we have sort of come back to a full circle. There is not much research in them. There is not much evidence to guide our practice, and that's very unlike pediatric or adult ICUs, where there's a lot of work has been done in critical illnesses because they only deal with critical illnesses. They don't have preterm babies who are otherwise well, who are staying just for developmental care. They only have sick patients. We don't. Our majority of patient population actually needs gentle family, family care, gentle care, because they are actually otherwise well. They just need maturity, development, and protection from complications. But there is a minority of population who actually develop critical illness, just like pediatric critical care is, and they need that type. They may need that type of approach, but we don't have. So we basically are back to where we were 1960s, 70s from a critical point of view, that we don't have the evidence to actually manage the critical illnesses. And then what are the skills that we need as clinicians in the bedside for that particular aspect, and how do we get them? So recently, just to quantify the burden of this critical illness in Canada, we conducted a study through CNN. Now, our challenge was that there is not even a definition of critical illness in babies that we know. What do we use? So we basically used all babies who get illnesses, who get medications which are only given for seriously sick babies, and that was inotropes and inhaled nitric oxide. And we also use a definition which was that you need to have that exposure for a prolonged period of time. And what we found is, over a 7-year period in Canada and NICUs, 2,915 babies fulfill the criteria. That's 10% of all admissions. 1 in every 10 babies who got to an ICU ends up facing a critical illness. And that's less than 32 weeks. The lower you go, the more chances become. So it's an inverse relationship. And if you go to the next slide, Fab. So then we also looked at what happens in these. We divided them into early period, which is at birth, first 3 days, and late. And you can see more were late than early. Late onset critical illness were far more common than babies born with critical illness. But if you look at their mortality, they actually amount for substantial. The overall combined mortality in these illnesses was 30%. That's a lot. And if you look at the variability between units, you can clearly see some units report mortality as low as 25% and others have as high as 60-70%. And same goes with the incidence. The percentage of babies who get exposed to these medications or these illnesses range from 7% to 2% at early and 16% to 3%. What does this show? It basically shows a complete lack of consensus. Who do we give this medication for? How do we manage them? How do we come in a point where our outcomes are similar in these really sick patients? We haven't focused on that. Data to benchmark ourselves. We have done a lot of benchmarking and very, very good reasons for infections, for chronic lung disease, and things like that. But we have never benchmarked ourselves for critical illness, which is a significant problem in this population. Next slide, please. So, in that sense, as always happened in medicine, the need comes first, and the research and the clinical skills develop afterwards, as we try to catch up and try to serve the population to the best of our ability. There is a practice lag. There is a research and practice lag in critical care in neonatology, and I'm distinguishing critical care from intensive care quite consciously. For example, if you think if so many babies are needing inotrope, we must have some studies telling us which inotrope is better. Inotrope is a medication we use to support heart function, but we actually don't. We have no data to tell us which inotrope is better. Nobody has studied it well enough. What is the definition of sepsis? What is the definition of shock? How best to manage it? Have we studied it? No, we haven't. Acute pulmonary hypertension. Which babies are better served with giving INO? How to give it? How to wean it? There are no guidelines. There is no quality improvement initiative till date, and there is no data registry and minimal research when it comes to critical care or critical illnesses in premature babies. And that's in contrast with what happens in pediatric and adult population. They have a lot of data, a lot of studies. They have data registries that they are learning from, and we are now beginning to catch up. Next one. So we are beginning to catch up, and as I said, the need comes first before people realize that we need to do something about this and start learning. So if you look at last 6 to 7, perhaps 8 years, a lot of this work has beginning to come. It's in a very early stage, but it's beginning to come. There have been a development of acute kidney injury collaborative, particularly for babies. I've read a big group came together to try and come up with a definition of ARDS. The NSOFA is a score. The SOFA is a score that they use in infections in adults. For the first time, it was adopted for newborns, and people are examining its ability to pick up at-risk newborns. Technology is coming around. Lung ultrasound is beginning to be used more. Point of care ultrasound, which is called POCUS, is spreading in the NICUs. We still don't know how best to use it. We're trying to figure it out, but it's happening. Near infrared spectroscopy is increasingly being used in care of these babies. And we need these because we cannot, unlike adult and pediatric patients, we cannot do invasive measurements. We can only do non-invasive, safe technologies. And one of those technologies where I'm going to focus on, which is my focus, is targeted neonatal echocardiography. That has also come about, and I'll move this thing a little bit forward. Next one. So what has happened at Mount Sinai Hospital, where I work, we have got together and we have created guidelines for the first time for monitoring and management of babies who have infection. Now, there are a lot of quality improvement and very, very important quality improvement work in prevention of infection. But we know we cannot prevent 100%. Some babies will get it. Now, we have come together to form a guideline of how to best manage that so that we can minimize the burden. We also have developed guidelines for blood pressure management in patients who become hypotensive. We're doing a lot of research on use of in acute care research, where we're studying acute pulmonary hypertension. We are studying infections, blood pressure, trying to define targets. And as I said, the TNE hemodynamic program. We also have now put together under EPIC. We have launched a subgroup which I lead with Dr. Shobik Mitra from Nova Scotia on hemodynamic management. And within a part of that, we are developing bundles now for hypertension management, for pulmonary hypertension management, so that we can all get together and brainstorm for the best way to manage acute illnesses, and hopefully through that reduce the variability and improve the outcomes of patients who become critically sick. Next one. So as I was saying, my main focus is targeted neonatal echocardiography. So what is it? It basically the need of TNE came about because we don't have invasive measures. We have these babies. Babies have very subtle signs. They all present like similar features. You cannot examine a baby and find out what's going on in the heart, what's going on in hemodynamic, because they're just a different breed altogether. Because of that, people developed skills. The neonatologists developed skills of scanning the heart, ultrasound the heart, and understand the hemodynamic profile in a particular situation, get the information from about blood flow, and then put it in context, and then make appropriate physiology driven decisions. So that's what TNE program really is. And so what typically happens is that the attending clinician, when they are dealing with a hemodynamic problem, they will ask for a consult. People will do a scan. They will measure all the blood flows in the heart and in the lungs, and then we'll put that information in the context of the patient, and then suggest management to alter that pathophysiology. But the final decision rests with the clinicians, and then based on the response, we will reevaluate to see whether things got better or how else to titrate. The utilization is typically on the clinician staff. It's just like X-ray. Somebody asks for an X-ray. Similarly, they can ask for TNE consult. And on the right side, I can put there the typical reasons why clinician will ask for a consultation. But in that, I'm going to primarily focus on acute critical illness, because we have recently examined the impact of this in this particular patient population. Next, please. So we aren't the first one to do it. To be honest, it was actually developed by a very close friend of mine and my first mentor, Dr. Patrick McNamara in SickKids in 2008, when I just came for training, and I trained under him. Then at Mount Sinai Hospital, we set up the second program in Canada in 2011 when I joined. And then since then it has spread. You can see on the graph on the map in Canada right now, and this map is 2 years old. Right now there are 17 centers in Canada which have this subspecialty already developed within the NICU, and they are performing to different levels and obviously for different indications. But they are actually performing hemodynamic assessment, and now it's spreading to United States. We now have 8 or 9 centers, and more centers are coming on, asking to be trained and asking to develop this program in neonatology. We have previously shown both from SickKids and from Mount Sinai that this particular consultation leads to a change in clinical management more than almost half the time. And in critical illnesses, almost 65-70% of time, when we provide a consult, the clinician tend to change what they were doing for the patient based on the information gathered. So essentially, we demonstrated its utilization in clinical business. What we didn't know at that time, that change leads to better outcome. Does it what it was mainly designed for? Next slide, please. So what we did was, more recently, this is just this year, we did a research because this modality is not used universally or wasn't used universally, and we had a lot of data sitting in our repository. What we did was we examined babies who fulfill a criteria of critical illness, means they needed inotrope or inhaled nitric oxide for severe symptoms in an acute way, and we compared those in whom a TNE consultation was actually used to those in whom it was not used within 24-hour period of illness, to know exposed and unexposed babies, and try to see whether TNE consultation made any difference. And as you can see there, the percentage of babies who die from these critical illness was much lower when a TNE consultation was actually used than when it was not used. And that actually stayed significant despite accounting for their illness severity. Next slide, please. And when we looked at the subgroup analysis, just those babies who need inotrope for hypotension, you can see the impact is even bigger, 16% versus 28%. So essentially, what we found is that early in the course of acute critical illness, if a TNE consultation is used, a hemodynamic consultation is used, and physiology driven decisions are made, then the survival from the illness till discharge is much higher without any increase in major morbidities within the NICU. So it's not as if we are causing them to survive and they are having a large brain bleeds. That's not what happened. In fact, the brain bleeds were lower in patients who were managed physiologically versus those who were not. So this was the first time we actually demonstrated an impact on patient outcome. Obviously, it's retrospective. It's not something which is not a randomized controlled trial, but at least we are moving somewhere. So this is a publication that we are gonna submit for publication this year. Hopefully, trying to raise awareness among the community that physiology driven decisions are helpful in critical illness. Next one. Right. So I'm going to share some case histories. They are just a few case histories from my own experience. They don't necessarily have to have happened in Mount Sinai, so please don't think that they happened here. But they're just a few. And just to highlight the point, yeah, we can move. Next. So this is an example, a baby who's born at 37 weeks, who had rupture of membrane since 15 weeks. And some of you might understand what that really means in the context that the lung doesn't develop if the water break very early. Baby was born and after that was put on CPAP, NIPPV, intubated at birth, high frequency oscillation, nitric oxide, nothing was working. And the baby was requiring 100% oxygen. Next one, please. And had severe acidosis, as you can see. We can move on. And that's how the clinicians feel at the bedside now. They've done everything that the evidence has taught us. Now, where do we go with this baby who is actually, we are not able to oxygenate and is severely acidotic? So they ask, a few more things were done. Nothing really helped at the time. And then a TNE consultation was asked at 4 hours of age. Next. And this is just a scan. Like, this is what we oftentimes find in these cases. This is the heart. And you don't have to truly sort of understand it, but you can just understand this is a heart chamber, and it contracts, it becomes smaller. As you can see in this heart, the cavity size is not becoming smaller, which means it's failing, it's not working. And that was the main problem in this baby, which we were able to diagnose early. Next slide. And the same thing, and from another view, you can look at the ground cavity, and it really should become small and big, but it's not. It's basically just stuck there and just rocking with motion, but it's not contracting. So in this particular child, the symptoms were primarily driven because of heart dysfunction. And so what we did, next slide, please. So what we did was actually put him on a little bit of medication to support his heart function and increase it. And you can see the oxygenation, it improves dramatically. And within 24-hour period, from needing 100% oxygen, unable to oxygenate, we were down to room air just by improving his heart function. And then we were able to wean off everything. And the baby was actually off the ventilator in 2 days. It was the most dramatic recoveries. And it's not a one-off case. We've seen this many times. When we diagnose the right problem and can titrate our therapies for the right for the issues that are underlining the symptoms, we are able to actually improve these kids' symptoms quite dramatically, and not much different than pediatric or adult ICUs, where they actually use the ultrasound quite more than what we used to. Next slide, please. Yeah. These are just some quick examples. Friday 7. These are real case stories. I have kept the story same, but I have changed the gestational age and the age and stuff to keep anonymity there. This is a example at 7 o'clock in the evening on a Friday. I was actually in the elevators trying to go home after handing over, and I was already off shift. And this is very early on, when I was the only one doing this. I heard a code ping from the unit, which I was surprised by. So I actually went back up, even though I don't have to, but I just thought I'll just check in what's going on. And when I went back in, I found that there was a baby who had a certain cardiac arrest. For example, a 27-weeker, not too far away from what my fake numbers are here. 8-day-old who was in CPAP doing very well and suddenly just had a cardiac arrest. The team was doing the CPR. giving epinephrine, nothing was happening. And the question was being raised, should we stop because it's been long enough? But because I was there, we were able to quickly scan the heart. And what we found was that the baby actually had a very big pericardial effusion. So basically, the TPN that we were giving through the PICC line leaked out of the heart into the cavity around the heart and compressed it and wouldn't let it function. Sorry. So what we were able to do immediately, because we diagnosed it, we were able to actually put a needle through the chest and drain that fluid immediately. And the moment you drained, within 30 seconds, the heart started functioning again. And this baby after that had no further complications. He survived. And from the last I heard from the follow-up clinic, the development was actually normal at 2 years. Next. This is another case. This is a weekday. It was 9 o'clock. I will never forget this case. This is probably the most weird thing in my life that has happened so far from a clinical point of view. 9 o'clock in the morning, I was trying to get out of the house, and my 2-year-old was pulling my pants in the kitchen, trying to drag me to the car. And I got a phone call from the unit, and I picked it up. And the same story, a well-stable infant suddenly had cardiac arrest. And the team is doing CPR for a pretty long time, for 10, 12 minutes, nothing was happening. And when I heard the story, I basically said, you have to drain the heart. It must be this and can't be anything else. But nobody has done it, and they don't know how. And so I was put on speakerphone. My phone was kept on the incubator, and I supervised the procedure from a speakerphone from my home. And the team was easily able to do it when somebody told them how to do it. And they drained the TPN, and again, the heart rate came back. And by the time I reached hospital, the kid was down to room air again with normal blood pressures. And the next day was completely back to baseline and never had any further complications. Next one. This is another case, and this was not pericardial effusion, just so that saying that that's not the only thing we do. A baby who was born at preterm with the rupture of membrane with no fluid for a long time. And as I said before, these babies oftentimes have lung development problem. Was born overnight, has ventilation failure, oxygenation failure, nothing was working. And the impression of the clinical team was that there is not enough lungs for this baby to survive. And a discussion was happened with the parents to say, should we stop because we can't do anything? And the parents were not there yet, and they were not ready, and they just wanted to stay put for some time. And so in morning 8 o'clock when I arrived, the clinician, to their credit, actually called me up and said, listen, we have this kid who I don't think have enough lungs, but we are doing everything. So we were wondering if you want to have a look and tell us if there's something we can do. And again, we found severe cardiac dysfunction, which was the main reason why the kid oxygen would not improve. And we just give, like the previous kid who was a term baby, this was a preterm, and same management, and it worked like a charm. And then this baby also, once we fixed the heart function, oxygenation improved and recovered very quickly, and actually went home on oxygen and is doing quite well. I'm still in contact with the family quite regularly. So they just showed these are some of the examples, and they are not isolated cases. We come across acute cases like this often enough to know that there is a need. There is a need for skills, and there's a need for having to be able to understand what's going on a more urgent basis. Next slide. And this is just an example. We even publish these case series just to raise awareness among the community that this skill is needed in the NICU. Not for all comers, but just the babies who become sick. They can really benefit by having somebody who can diagnose their underlying problem. And it is this that motivated us to actually do the study, to examine the impact on outcome. To be honest, but my colleagues were a little bit scared. Some of them said, what if you find no impact? Then does it mean we should stop doing this? This is our career. and I was pretty confident that we will find an impact because I've seen it. Next slide, please. So what did we do? How did we set up the hemodynamic program? And this is just a timeline. It takes a lot of effort, and I'm not the only one. To be honest, there are 17 centers in Canada, as I said, and I was not the pioneer person. I was the second person who came around there, and I was very fortunate that the Patrick was there already, who had done the initial groundwork and helped me set up the program in Sinai, which I actually joined in 2011. And I had one of my very good friends as my sort of co-founder. His name is Dr. Afif Al-Kafa. He works in Ireland now. His help was really important at the time. We We were just two physicians. We had a medium quality machine that was here. There was no archiving system, no reporting system. We will just get called every day, weekend, night, evening, and we will just go and help out and we'll try and diagnose the problem. And the more we were successful, the more we were getting called. Um, so it was quite a busy time, but it actually demonstrated the need. And to be fair, I work in a setup where the leadership, both from a nursing and medical point of view, are very, very supportive and completely understood how much that this is required and gave me a lot of support and infrastructure. And you need that if you want to develop it in your unit. You're not going to be able to do it without it. So in 2014, a new state-of-art machine was bought. We developed the local archiving system. We established a collaboration with cardiology in sick kids. We had sonographer scans. We developed IT systems. We made it a seamless transfer from an ICU to cardiology, so we can actually get them involved in a minute's notice. And finally, in 2018, we formalized a 1-year hemodynamic subspecialty fellowship training program because we wanted to train people at the highest level possible. And today, 3 of my colleagues actually share this workload with me, and they're fully trained and they share responsibilities. We have a tri-hospital Toronto teaching program for hemodynamic fellows. We have at any given time point 3 or 4 fellows at different stages of their training in the unit. We have already trained about 9 or 10 people, of which 8 are working in level 3 NICUs in their respective countries and provinces and leading their own program. And by doing so, we actually are able to provide provide an all-day coverage, including majority of weekends, because one of our trainees are always on service. We still don't have a 24/7 coverage, which is really hard, but that's where I really want to be. I think we need 24/7 coverage, but how we're trying to make a case for it and how to operationalize it, because it's a very resource demanding system to have somebody on call all the time for it. But we're not there yet. But this is how far we have come. A similar system now exists in Sunnybrook Hospital also. So both Mount Sinai and Sunnybrook work in collaboration. We have a common training program, common protocols, and we are doing common research in the particular field. Next, please. And more recently, we have developed this is a vision I had, that we are going to move to an international platform. We want to actually develop a virtual center where a lot of people who are doing this work now in their own respective countries and unit, we bring them together. We create an international network of experts who will develop guidelines, who will develop policies, who will publish them, who will provide leadership to the world, and provide an education platform to clinicians and trainees who are interested in the particular field. And so we've been able to create this virtual center, which is right now under construction, and it's called neonatalhemodynamics.com is the website. And what we're going to have starting in the next 2 months is we're going to have 3 webinars on it per month, actually dedicated to neonatal hemodynamics only, dedicated to trainees who want to learn, who are learning these particular skills, and they'll be listening directly from experts from all over the world. We're going to have interesting case series being published on it, just like I showed to what I showed here in brief, but actually what was the physiological points that we could learn from it. And not all of them might actually need to do a scan. Once you learn, once you know what's happening, you actually can manage many of these conditions without doing a scan, because you know, because you have seen it so many times. So we're going to do that. We are also going to develop mentorship program within that for new faculties to help them develop their program at no cost, obviously. And as I said, one by one, we're going to develop guidelines about management of critical conditions in these patients. So right now we have 27 centers from Europe, North America, 1 from Mexico and Canada, and Ireland. So Ireland is a part of Europe, sorry. So 1 in Ireland, UK, Spain, Italy, and Netherlands, Canada, United States, and Mexico. So these countries have been covered, and 27 centers have got together and agreed to be a part of this particular initiative. And we are hoping that we will have a lot of activity, and we're going to keep building up on it. And yeah, and the final goal really is to generate evidence, to actually do large scale studies, and create the standard of care for critical illnesses which affect hemodynamic care in preterm babies. That's the vision. I think I've already spoken a lot, so my time's up. I'm happy to take any questions. Sorry, you are mute, Fabiana.
Okay, I'm mute, of course. 1 year later, I'm still on mute after this. But thank you so much for your presentation. And I really want to thank you for this incredible work. And you're really leading the way to many other countries and many other clinicians to learn from you, from your experience. I'm very grateful. I actually met you in 2012 and my son was in your NICU. And I remember when you came to this echocardiogram on Gabriel, I had not realized how sick he was. And I'm very grateful for all the work that you do what you did for my family and the work that you do for many other families. So thank you for that. So I guess my first question to you is, what does it mean for babies and families? Can you hear me? Yeah. Okay.
Sorry, you're getting a little, am I?
Yes, I asked you.
I think I lost you for a second.
Okay, that's okay. I asked you what this work means for babies.
Breaking up, Fabiana, and I'm not sure.
Okay, I'm not sure why, because my
so if I gather correctly, you're saying, what does this mean for the family?
Yes. Yes.
Yeah. So I think one of the best things I have done in the last few years is actually get together with you again on this particular platform, and understood the importance of involving advocating families and in our research programs, and platform like these. So I think I do think families have a role. Now it might not be a very popular thing to say right now, but I do think that they have a right to know what exists. They have a right to demand certain things for their babies, but they don't know right now, right? So if a particular unit doesn't have this system, for example, or a particular clinician, a particular place doesn't want to use this and they want to just do it themselves without actually, they wouldn't tell the family wouldn't know that there's an option of an investigation that may help. And I think that's where I take it in a very it's not exactly that, but in a very rudimentary way. I think the power needs to stay with the customer. I think customer must know what they're getting into and what are the options they have. So I think once we are able to generate that degree of awareness, I think the families are very powerful advocates for their children. Nobody has more stake in that child than that family, and they will always want the best possible solution. And in some cases it might not be the best things, and in that case something else. But I think for that to happen, we need to involve families. And as you can see, and a lot of things I'm doing, I'm constantly chasing you around for a parent representative on on studies and plans and grants, because to be honest, I was just ignorant, just working on my own and doing scientific work and thinking that everything will just spread on its own, but it doesn't. And I do think engaging advocating families is really, really important. And if you make enough evidence and you make enough noise, there is no way that the families wouldn't themselves ask for it.
Absolutely. And I think this is such an important point for the families to absolutely know about this and how to get the best care for their babies. But we also know the change takes time, right? Implementation takes time and takes a lot of effort, and is also the financial aspect. But I'm hoping that with all your evidence and this international group that you are forming, things will move forward faster. And I'm hoping also you're going to include families and parent organizations in your new project, because I think this is a great place for collaboration for all of us to work together and to improve outcomes. But my question is for the babies, right? So how you talk about, babies getting more stable once you have the intervention and we figure out the exact problem. But in the long term, have you seen the long-term impact of those interventions?
Right. Yeah. So that's again, I have a little bit of a different take on it. Um, I completely agree. I think that's a very important aspect of neonatology. But I do think that we don't give enough credit to preterm babies as we should. I think they are far more resilient than what we think, and we are a little bit too paternalistic in that sense. But I think it's a responsibility lies on us to make sure that we are checking that, we are evaluating that, we are giving them the best possible, even long-term care, because we do want to provide the best possible long-term care, and that's incorporating the long-term outcomes and keeping a track of families. It's a lot of hard work in long-term outcome because it takes so many years. It's just easiest thing to do is short-term, but I think that's important. We have published, and this is why we published about 3 papers now on it. 2-year developmental outcome of acute patients which we managed, and to our surprise, to be honest, the patient who survived, they were not any worse than patient who didn't have critical illness. We were able to actually have quite a good outcomes. So we have 3 papers now on it. We did that for patients who survived after intervention, having suffered the same type of disorder I showed you, 100% oxygen after a rupture of membranes, and we had to we sort of do critical care to make them survive, and their outcomes were not bad at all. They were actually quite good. So we are trying to establish that, because that's always the case, especially in neonatology. The moment somebody gets sick, our first thought goes, what does it mean long term? We don't think like that when a term baby is born, to be honest. We are just focused at that time in saving an acute life, and I've seen that myself, and that bugs me. A preterm baby is just as important as a term baby would be, or a term baby is just as important as a 1 year would be. I mean, I'm not saying that we shouldn't evaluate their outcome. We do have that responsibility, and there are ways around it. But I do think that we shouldn't prejudge.
Absolutely. So my next question is, what is your team called in the NICU?
Sorry?
What is your team called?
What is my team?
Yeah.
Whatever people think at the time. Some people just say AU.
No, but I
no.
To become a subspecialty of neonatology, right?
Yeah. So we again, we haven't branded or anything like that, but now with the specialty fellowship coming through, we typically are called neonatal hemodynamics team. It's a hemodynamic team.
Okay,
because we hold special expertise in hemodynamic care.
Okay. So, and do you see the field of neonatology going to these subspecialties?
Sorry, again, I lost you a little bit, but I think you were saying, do I foresee neonatology going into subspecialty mode?
Yes.
Right?
Yes.
Right. Now, where do I see it going? In the immediate short, in the medium term, till I get old, I think that's unavoidable. I think neonatology will go the direction the pediatric critical care is. I think we are going to evolve into a critical care specialty. We were a critical care specialty, but our demands were different. Then we became a intensive care specialty where majority of patients are great. I mean, that is credit to those people who work tirelessly in discovering all these discoveries and making life so much easier for the majority. But once that happens, the focus starts going on what's left. What's left is this critically sick babies. We need to manage them better, and I think that's where we are going. And I won't not be surprised if the skill levels are going to go up, because these things are coming through. As I said, lung ultrasound, non-invasive monitoring techniques. The studies are already start coming. For the first time, we had a study.
I think we lost Dr. Jain's audio. Oh, yes,
right.
you froze.
That was my Wi-Fi falling apart, needing me to reconnect. So I think it's going to go subspecialty mode, but it's going to take some time. People are going to navigate some people will do it well, and some people will not do it that well and fail, including me in some cases. But we will going to become a critical care specialty again for these babies particularly. There is no getting around it.
Okay, I just want to share congratulations from one of our Facebook live audience. Thank you, Rita, for watching us. And I know you're not on social media, Dr. Jain, so I'm sharing here with you today. But I really want to thank you for sharing your knowledge, your expertise with us today. I'm very grateful that you took the time to share with our audience all that you've been doing for the babies in Canada and worldwide. Okay, maybe
thank you so much for having me over here. It's a pleasure.
Thank you, Dr. Jain. And for all of you watching from home or the hospital, either on our YouTube channel or Facebook, thank you for joining us here today. The video of today's session and all the other videos from our live sessions are available on the CPBF website, which is right here, canadianpremis.org. And I also want to thank our sponsors, AbbVie and Water Wipes, to make our session possible today. And we are a charitable organization, and we believe that through education and support, we can empower families, ensuring they're ready to take care of their premature babies. Please visit our website, consider making a donation. Together, we can create a brighter future for all families. So I see you again next Friday, 1 p.m. Eastern Time. Thank you. Stay well, everyone.